go ahead and start this webinar. Welcome everyone. My name is Snorri Helgason. I'm the product marketing manager at Nox Medical. Welcome to this first webinar in the webinar series called See Everything at Once on our polysomnography. For the first webinar, we will be talking about the Nox Self-Applied Somnography. And what is the Nox Self-Applied Somnography? It is basically the Nox A1 with a system that helps the patient hook themselves up in their own home and hugely simplifies the process of conducting polysomnography. It is currently only available for research purposes. And the reason for why we are doing this webinar is to first and foremost welcome Dr. Naresh Punjabi, who will be presenting his own results using and applying the Nox SAS system in the MAX study, which is a multi-center age cohort study. And Naresh will probably talk a little bit more about that. But Dr. Naresh Punjabi is a professor of medicine and chief of division of pulmonary critical care and sleep medicine in the University of Miami, Miller School of Medicine. And he's the chief of pulmonary and sleep medicine in the Miami VA. So welcome, Naresh.
Thank you, Snorri. Welcome everybody, and thanks for coming. Let me start by sharing my screen and there we go. So good morning, at least from the East Coast of the United States to wherever you are. Good afternoon to the folks in Europe, and good morning to the folks on the West Coast of the United States. The charge I've been given is to talk about our experience with this technology developed by Nox on trying to do polysomnography at home. Of course, many of you know that one of the hardest and daunting challenges for assessing sleep, whether it be for the clinical environment or the research environment, is acquiring sufficient data quality, particularly understanding whether we can really monitor sleep at home with the EEG. The typical respiratory polygraphy that most of us use in clinical practice, of course, does not have the EEG because it is difficult to do these things at home. Now, there are monitors that are available that can allow us to do this that use some measure of a frontal montage to collect EEG data. The self-applied polysomnogram, which I will illustrate in the multi-center AIDS cohort study, is unique in the sense that we actually have a full EEG, which represents the frontal montage. It's unique in the sense that it can be self-applied by participants or patients. And we have now accumulated experience in over 1,000 individuals where we've been able to do this without much instruction. And not only is it feasible, as I will illustrate, it's so convenient and cost effective that it makes sense from the standpoint of application, whether it be a clinical environment, research, or a research application. So let me tell you our experience with what has happened in this study called MAX. The MAX is a multi-center AIDS cohort study. It is one of the most landmark studies in the world that has contributed to our understanding of what HIV infection does from the standpoint of clinical outcomes and how to manage it. It started in the mid-1980s, and now in its almost 40th year, it is a cohort study, which is characterizing how the natural history of HIV and treated HIV is in men who have sex with men. It originated in 5 cities: Baltimore, Washington, Chicago, Pittsburgh, Ohio, and Los Angeles. The unique aspect of this study when it started is that it included not just HIV-infected individuals, but also HIV-uninfected men. It started in 1984, and it's gone through several waves of data collection. Every 6 months, these individuals go for semi-annual visits, and they have standardized interviews, they have phlebotomy. In the year of 2018, when it was going to the next, we actually added on sonography. One of the challenges was, how do you do studies for research, which was the forum here, in such a large population, which is in the thousands, and do it such that it's cheap simple, good quality. And how do you do it without expertise in sleep medicine? That was very critical for us. The individuals that were at these different cities and sites were not sleep trained. In fact, none of them were. We were the only central sleep reading center, central sleep coordinating center that provided very minimal, if any, education to the sites and the technicians, who again were not polysomnologists or respiratory therapists. They were research assistants that you would encounter in a clinical environment. So we were able to develop methods, which I will share with you, on how one can actually acquire sleep. And just by coincidental circumstance, Nox Medical was developing this technology on self-applied polysomnography in around 2018, and we were fortunate enough to acquire that work and get their assistance in collecting polysomnography in 1,014 individuals that we have done so far. So let me walk you through the whole thing now. If you don't know, the Nox A1 monitor looks, for the most part, almost a beeper-sized device. You can do full montage polysomnography with Nox A1. The configuration that you'd want with any sort of montage can be delivered with this monitor. It communicates to other monitoring devices, such as the Oximeter by Bluetooth connectivity. It has impedance bands. It can monitor ECG, and what you would typically consider standard with an in-lab study. The unique aspect of this is that concept of self-applied. Now, why is it self-applied? The reason it's self-applied is sort of this innovative cable, and there's sort of different variations of this in this slide. What you notice is that there's a cable that goes from the monitor itself to the frontal area. And the convenience of the frontal montage is that a participant can put the electrodes on by looking in a mirror and place them very carefully and without much discomfort or difficulty. They are placed in a circumferential manner. There are 5 touch points, 2 that are centered around the eyes, 1 at the vertex of the frontal center, and then 2 in the middle. And you can see a graphic of an individual on the left side, and you've got an actual individual that's configured with the Nox A1 and a close-up view of what this lead looks like. Aside from this lead, everything else that you are familiar with from the standpoint of polysomnography, whether it's the use of nasal cannula, as you see in this individual, or the use of electrocardiography, or even monitoring leg movements, are available and can be done with the configuration that you see in this individual in the middle. So the basic premise is pretty straightforward. We have developed over the years methodology so that individuals would have access to videos so they can watch and learn from a video. We actually have also mannequins that we have our clinical settings so patients who are coming in or research participants that are being enrolled can actually look at a mannequin and look at a configuration of this while they're visiting us. And then we've also developed cards or note cards that we insert in every packet that we give to the participants. And here are the examples that what we've done from the standpoint of easing application for the participant or the patient at home. We have gone through and with help from Nox and developed these note cards that are laminated and inserted in each of the participants' kit. We walk them through step by step of where the electrodes go and how to actually go ahead and prepare that area. So, for example, these 4 electrodes, which allow monitoring of the electrocardiogram, are placed in these locations designated in this figure, and we instruct the individual to go through and clean the area with an alcohol wipe in this case. All the electrodes are placed, at least for this step, in these 4 locations. And each of the electrodes are provided in convenient, simple plastic bags that they can follow and use. And that's why you'll see this nomenclature of bag 1, bag 2. Now, Nox has since migrated away from bags and developed even a more efficient kit. But for the MAX study, we used this platform of electrodes being partitioned in different color-coded bags, so it'd be easy for the individual to pull them out of the kit and apply them. So for step 2, you'll see that we instruct them on how to place an electrode on the leg itself. For the most part, we've been quite successful in these signals. And at the end of this presentation, I'll go through what our feasibility, our success rate, and signal quality look like. So this is an example of sort of the second step of placing leg electrodes. And we're able to walk them through about how these cables should be, whether it's an undershirt or nightgown. We tell them how to clip on, of course, the cables to the electrodes and how they should be routed under their garments that they wear for the night. We also walk them through any connectivity issues that they may need to go through. Everything is pre-set in the clinic before the kit is given out. So for example, the nasal cannula is connected to the Nox A1 monitor. The participant has to, however, connect the cables into the monitor itself. So they're relatively simple instructions that they can go through. Here's an example of how to connect the effort belts. The next slide is about the electrodes on the frontal, for the frontal montage. And again, we walk them through to make sure that they understand they need to go ahead and clean off the area, and we give them the alcohol wipes inside the kit, so everything is available. They don't have to go outside that closed environment of a Nox A1 bag. And this is relatively simple. We do recommend that they be in front of a mirror, but it's not necessary. I think being in front of a mirror does help to place these electrodes in the right place. And then finally, clipping on that half a halo cable, which connects to the Nox A1 monitor, is relatively straightforward. And we really haven't had much signal loss, signal artifact with regards to the EEG. And I think most of you will be surprised that EEG is not one of our signals that is most problematic when you try to do home full montage polysomnography. Finally, we also show them how to place a nasal cannula. Now you'll note we don't have a thermistor in this device, which is perfectly fine. For our 1,000 or so recordings, we've acquired good quality signal with regards to the nasal cannula. So there is no thermistor, at least in this configuration of what we have. And finally, placement of the wrist oximeter, which is already paired via Bluetooth connection to the Nox A1 that's in the bag. We're very careful about triaging this equipment. We don't dissociate the oximeter from the monitor because, again, they're paired using an address that's unique to each oximeter, which is then configured via the Nox A1 software into the device itself. The monitor, I should note, is operated by a AA battery. When we started the study, we were using rechargeable batteries, but since then, we've actually abandoned that approach. While it was very efficient, we abandoned that approach and now just use an isolated AA battery. One has to be very careful which AA battery to use because different types of AA batteries have different drain rates. And we've noticed that with a lithium AA battery, we can get about 8 to 12 hours of recording of the entire montage with regards to one individual. So there's enough charge on one AA battery for us to last a full night of recording. And then again, we remind the individual to start the recording, or in this case, what we have done is we've actually configured the recording to auto start because I think it is easier. In the clinic, we ask them, what time do you plan on going to bed? And typically what we do is we start the timer for the monitor about 30 to 35 minutes before their designated time to bed. And then the monitor continues and we configure it to record for 12 hours. Even if they take the monitor off and the battery still has charge, it'll continue recording. It'll just be a no signal from the standpoint of EEG or the other inputs. So one of the questions for us was when we first started doing this, and I have to admit that we sort of did a deep dive into this, and fortunately we were quite successful. We, in collaboration with Nox, were able to complete a data set of 943 participants. It took us 14 months to go through these 43 participants in the MAX study. And what we noticed and during our year and a half of doing this is that out of the 943 individuals that agreed to have home polysomnography, we were able to get good quality polysomnography data on 793 individuals on just the first attempt. We did go for a second attempt on those that failed, and we were able to get an additional 58 individuals to give us good quality sleep data. But what is good quality sleep data? We considered acceptable if we had all of the signals at least present for 3 hours. This means oximetry, belts, the EEG signal, ECG signal, and of course legs. And if you just look at the numbers that we have, we were able to get successful home polysomnography, which includes, of course, the EEG, in 90% of the time. So 90% of our 943 people could get it within 2 attempts. Of course, a majority of these individuals, 793, or roughly 85 to 86%, were able to do it in the first attempt, meaning give us 3 hours of good solid EEG and other signals, as I outlined before. Simply put, 90% of the time, you can get an acceptable study that will provide us all of the information that goes above and beyond respiratory polygraphy, and of course, including the EEG 90% of the time. Now, we also tracked what happened to us over time. What you see here plotted is the number of studies that were considered successful. And I define success as having at least 3 hours of all signals in our studies. So let's go through this graph in a little more detail. What this shows you, in the first month, we did 60, we ramped up to 104 studies, and this line here shows you the number of studies we did per month over the 14-month period. And the line above demonstrates the number, or rather proportion, about the successful studies per month. Across the entire 14-month period, we hovered at that sort of mid-80s number. So we could get a successful study 85% of the time on the first shot, which is what I mentioned in the last graph. And there was really no temporal decline. There was no improvement. I think all in all, the message here is that a sleep study using this technology, 85% of the time, you're going to be just fine getting the data right off the bat. You can increase, at least in our experience, success by going to 90% if you just attempt a second one for those that fail. Now, what was the reason for an unsuccessful study? We had 4 sites in this study, and we have shown the data here, all of them combined and by site, because there could certainly be site variations, because none of these people in the field have experience with sleep. And that's a point that has to be made. None of these sites were sleep trained. None of these sites had a sleep physician, respiratory therapist, or polysomnologist. So as you can see, we were able to do a total of 113 studies on 943. The reason for that difference is repeats. All in all, we noted that, again, that mid-80s number, 16% were unsuccessful, okay, on the first attempt. So if you do that, the question is, why do they fail? What is the major cause of failure? Turns out it's not the EEG. EEG less than 3 hours was only present, or only the reason for unsuccessful study in 28% of the time. Majority of the failures were related to oximetry, not having a contiguous signal for 3 hours, or the belts, or a combination thereof. So it's interesting, one of the most sort of feared signals from the standpoint of signal quality was actually not the cause of our failure. It were the other signals, oximetry being, of course, the most common. And that trend was pretty consistent across all of our different sites. There were some site-to-site variations, but they were not statistically significant. So the message here to take away is that, yes, one can do polysomnography, including the EEG, and The trouble is not so much the EEG, which I think has been done well here. The trouble really is everything else, which is a problem no matter what. I mean, if you were to think about any respiratory approach to understanding sleep and breathing at home, you're going to see the same challenges. We then went on to say, okay, we can do successful sleep studies at home with EEG. How good is the signal? And I would show you some of the recordings we had. How good is the signal? So we rated them. We rated each signal. We rated them as excellent, very good, good, or fair, based on the duration of artifact-free data. And here's our criteria. A study was considered excellent if the EEG, oximetry, airflow signals, the chest wall, and the abdominal signal all were good for more than 5 hours. Very good was more than 4 hours, but maybe one signal was 4 to 5. So that's still not bad. If we got, let's say, 4 hours of oximetry, but everything else was more than 4 hours, that's what that criteria would take us. And similarly, good was more than 3 hours, fair was, same as good, but some of our EEGs had artifacts. We couldn't score them for individual stages, but we could say, we can tell if this is sleep or wake. So this is very much of an arbitrary definition for signal quality. And here's what we noted over the 14-month period. A majority of our studies that were successful were excellent or very good. We don't make a distinction between those because excellent or very good were so useful in every way that, again, collapsing them made sense. So 85% were very good or excellent. Even the good and the fair, which are the residuals, were quite stable over the 14 months that we use this technology. And you can see some oscillation, but there wasn't really a learning trend or a deterioration over time in what we were doing. Again, I want to remind everybody that this is not a sleep lab. These are not trained technicians that know how to do this. I do wonder if we were to think about having trained individuals disperse this information or technology, what this could do. But at least for us, where we did not have a labor force, where we did not have the resources for training individuals in sleep or how to do polysomnography, this is excellent from the standpoint of quality of data. We can further break that down and say, look, what does the proportion look like? So you can see, if you look at signal quality, excellent sleep studies constituted 72% of our entire batch of successful studies. Very good added on 14%. And then good was the residual 9, and then fair was at 4.8. Some site-to-site variations. But again, the main part of this table is to demonstrate that 85%, you're going to get very good or excellent. Yes, there'll be some issues because it's at home, no one's monitored. The cannula may sort of slide off for a little while, but then come back at a later point in time. So the quality is pretty good. So now let's actually look at some signals. I'm going to minimize my PowerPoint presentation and actually take you to a sleep study from this data set. I have randomly, purely by random chance, selected a sleep study. I haven't chosen one with the highest score. In fact, I don't know what the highest score is. So now let's actually review what the signals look like. I have opened up the software package that is part of the Nox A1 environment. And you'll notice what's displayed here is a 30-second epoch with the eyelids being on top, the AF3, AF4, and AF7, the derivation from the frontal montage. And then other signals, such as the cannula signal, the electrocardiogram, which is the ECG right there, saturation, and in fact, the EMG from the right leg. We have divided the recording up into two display templates. One of them just shows the sleep data in much more detail at the 30-second level. And then we have a template for respiratory scoring, which is here. Of course, all of these are customizable and you can do what is most convenient for you. But the simple part of this is that if you were to look at the respiratory data, it's fabulous. This looks like, for the most part, an in-lab sleep study. And in fact, when we were starting to do this work, we would ask sleep physicians that were looking at these studies, and do you think this is an in-lab study or this is not an in-lab study? And majority of the time, our physicians could not tell the difference of where this came from. Now, this is very interesting. The nasal cannula signal has fallen off, and that's why you see a complete flat line here. Now, whether the signal comes back or not, I don't know, but it gives you an idea of what the signal quality from a respiratory batch looks like. And again, the nice thing about this is that some of the software capabilities are quite useful. You've got the rib flow signal here. If we lose the cannula, we would use the rib flow signal as a way to score. So this is not dramatically different. There are some enhancements that are available, but this could be done with respiratory polygraphy. The unique aspect of this, at least for us, was the capability of also doing the EEG without having a technician go to someone's home. So this is very nice, beautiful looking stage 2. I'll scroll through a few epochs of this. We can see all the typical features of stage 2 that we see. There are some caveats that you need to know about. The typical references of the M1 and M2 are not there. So we came up with, in collaboration with Nox, how to reference the EEG lead. And as you can see, if referenced the way we have, it looks pretty good. We can actually see beautiful stage 2. We can see spindles and so forth. Excuse me. I'm going to now jump to an epoch of REM. And I will expand the eyelids so you can really see how the eyelids really show those rapid eye movements. And there's a perfect example here and here, also here, of rapid eye movements. So for the most part, everything that you imagine from a standpoint of scoring sleep was feasible and available with the self-applied approach, which would not have been possible had we just done respiratory polygraphy, of course, and doing in-lab polysomnographs for 900 or more individuals would just be cost prohibitive from a research standpoint. So the signal quality for us was quite good, whether it be looking at signal quality of the respiratory signals, chest abdominal bands, etc. So I'm going to go back to my presentation, minimizing this. So from what we could tell, this is pretty good. It approximates quite well what we would see in the lab. We also went in and looked at artifact. How much artifact do we get for the individual leads? So for example, the EEG, EOG, ECG, etc. And we quantified this just based using the scale of number of hours. This assessment was based on a combination of internal algorithmic input on how many hours of artifact does the software see, and also our visual inspection of the signal. And again, what's really remarkable is that if you see, most of our sleep studies have more than 3 hours of artifact-free signal for the EEG standpoint. What's fascinating is that's not the worst signal. The EEG and the EOG, in fact, are pretty close to the other 2 best signals, which is the chest and abdominal band. You get 6 hours of this information, right? I think most of us would agree that if you got 4 to 5 hours or 4 or more hours of EEG and other signal quality, that's good, it would be phenomenal. So the EEG and EOG and ECG attained that. Yes, there were problems with the ECG cable, and ECG did have less than 3 hours because those leads are really on the chest, and therefore there's a higher propensity for them to come off versus the EEG or EOG leads. Nasal pressure signal, not surprisingly, was the most challenging. We had it to be less than, it was the lowest from the standpoint of more than 6 hours of artifacts-free signal. The chest and abdomen, as you can see, are the best 2 signals, followed by the EEG. So this was really relatively good news for us. That is, we were able to do 1,000 or so sleep studies relatively cost effectively and get good quality data for us to not just look at sleep, but stage sleep in its subcomponents, including non-REM and REM. So what are the key messages that I'd like to sort of, leave you with from our experience? And I can go into much, much more detail about these findings. From our experience, we clearly can see that this is a simple approach. There are techniques that are available that we've developed and Nox has developed to make it relatively simple. We think it's extremely feasible, and we've shown that from the standpoint of how many successful studies can you get on the first attempt, what's your bump up in success if you were to do it twice, and so forth. Of course, it's cost effective because we're not paying the cost of an in-lab study, which again would have been cost prohibitive for our research attempt in this epidemiological study on HIV infection. And then finally, we're measuring sleep at home. So the conundrum or the problem that we often talk about in the literature about first night effects, of course, is not there. We are actually measuring sleep at home. So for whatever that means, it is as representative as we could get to individual sleep at home. Is it going to be exactly the same without the electrodes? Probably not. But it's, of course, more proximate to the home environment because it is in the home versus being in the lab. I thank you for your attention, and I think we'll open this up from the standpoint of questions.
Thank you, Dr. Punjabi. I will be starting a short poll now, and I will actually start with the first question. But please write in your questions in the Q&A. I will try to cover most of them at least. So I will just launch the poll, and I will throw the first question at you. So we have, from the standpoint of manufacturing and creating the Nox Self-Applied Somnography, we have actually got the criticism of, you don't really know how older people are going to be able to put this on, and patients that might have difficulties in doing this by themselves. Did you experience different kinds of populations? And because this is a rather large population, did you see any trend that the older patients were unable to do this versus the younger, or can you tell me a little bit about that?
Yeah, the age range in this sample was in the mid-60s. So we were in the older age range. A majority of these participants in the cohort study have been followed for well over 20 years at this point for some of them. So we didn't see that there was an association with age and signal quality. I know other studies have shown that, but we didn't see that effect.
Okay, and just to elaborate that, I mean, this is the question, which one was the median age, and did the patient have significant medical conditions? I mean,
they did. This is a very the neat part about having a cohort that has been followed for a long time is that they had a lot of comorbidities. Of course, they have HIV, but they have HIV-related comorbidities, everything from hypertension, diabetes. Many patients were using narcotics for pain control. So there was an extremely wide diversity. These were not healthy participants in any way. There's a very, very high prevalence of sleep apnea. 85% of this cohort had sleep apnea with an AHI more than 5. Almost 60% of the cohort had moderate to severe sleep apnea with an AHI of 15 or more.
Okay. And the questions keep coming in. So there's a question about the chin EMG. Where is that?
Yeah, good point. We did not, the montage does not include the chin EMG, and that's a very important point to discuss. We knew about this problem. So what we did is we actually took the frontal montage and came up with a frontalis EMG, and we used that as a surrogate for the chin EMG. So for the most part, you're right. Not having the ends, not in the chin, has a trade-off where application is difficult, or could be difficult for some individuals with regards to finding the M leads or trying to do a chin lead. So it doesn't include that. We did filter the signal from the frontal montage to get a frontal EMG, and we used that. We found two things. Number one, the frontal EMG was very helpful because when there was an arousal, we saw it there. So it was extremely specific. The other thing we noticed, at least with this technology, was that the activity monitor is extremely helpful. We noted that there would be a pickup of activity before even the EEG would show us an arousal. So there were many surrogates that came in handy as we were as we were, developing our own understanding and comfort with this. And again, so we substituted the frontalis EMG for the chin, and our referencing of the M's, or the absence of M's, we actually did a combined E2 plus E4. So that negated, they gave us sort of an isoelectric point, and we referenced all of them to that sort of center point of E2 plus E4.
There's actually a question here as well regarding the sampling rate of the EEG and alpha. It's also a question about how do you get alpha?
Yeah, so again, great points. The sampling rate, 256 hertz is what we had configured this thing to. You can alter that. The issue of alpha, of course, you're going to see more alpha because, on the occiput leads, we didn't have that advantage. But again, it matters what you're trying to do. For us, understanding stages of sleep was better than not having the data at all. So from a standpoint of what we're collecting, having really high fidelity data, sacrificing some of the nuances of alpha because of the occipital leads and other, we're okay. Those are the trade-offs we made, because now we have data on 900 individuals that we're not going to follow for a decade or more, and then we've got some sleep characterization. Otherwise, trying to do a full montage would have just been impossible. We just would not have been able to do it. So yes, you do give up a few things for the simplicity of what you've gained.
Mm-hmm. We have a couple of more questions, but I do wanted to share the results of the poll first and go through the questions and your thoughts on that. So I don't know if you can see them now. The first question was actually to ask our audience, what kind of PhD studies they were performing. And I can see that, to my surprise, that a lot of the participants here are conducting level 2 studies. I mean, why, and you said that level 1 versus level 2 versus HSAT. I mean, why is this a better way to do so? Why is that? Is it the cost effectiveness, or is it?
Well, it's the middle ground of the two, right? I mean, yeah. if we said everybody needs to come to a lab, clinically, even if we have patients, we have too many patients, then we have resources. So trying to do an in-lab study for everyone is just a non-starter as we move forward in the next era of sleep medicine. The issue of what is the added advantage? Well, all of the challenges that we know with regards to an 8-SAT are not here. We know sleep duration. We've got a better estimation of disease severity that we would lose had we not include that. So, it's a trade-off again. But I think the trade-off is in the favor and extreme benefit, in at least our experience so far, than what we would have gathered by just doing a bunch of home sleep studies with G. We would be lost, as many of you attending here would be, with regards to, well, what is the TST? We know nothing about sleep quality, et cetera. So I think the amount that's gained for the amount of burden that's imposed is so favorable, and the risk and the burden of doing an in-lab study, that this is a nice, perfect medium where we can get the information we want. Yes, it's not typical. Yes, it doesn't have the M1, M2, EMG, but there's a lot of data here that I don't think many sleep physicians that I've showed these recordings to have ever complained about the absence of an EMG on chin or the lack of an M1, M2 reference.
Oh, thank you. I can see that I can only put one question at a time in the poll. My intention was to actually put all of them up. So I can, maybe we'll just, for the sake of time, try to answer some of the questions that we have in the Q&A as well. There is one, considering the narrow forehead of some patients, will there be artifacts if leads are placed close to each other?
Yeah, it's not so much of an artifact problem. It's an issue of representation. What will happen is if they're close together, you're collecting from such close proximity that these signals, and I think it's a good thing, these signals are redundant. So one electrode has a problem, you've got 3 others that can give you information. So The proximity is not the issue. The problem, if you want to identify problems, is that you're getting relatively the same information. You're getting an EEG. Again, the advantage of the multiple touch points was when one drops, you've got 3 others that are available. So you get very good information, and you can score on all 4 leads and don't have to worry that all 4 have to be present. You can have at least one EEG, probably 100% of the time that's functional.
Mm-hmm. I think we only have time for one more, and there is actually one question in the chat that I would like to discuss with you, because one of the issues that we also face is the fact that in most countries there's not a reimbursement for this type of study. And the question here is that, do you feel that there will be better reimbursement for this type of study? And I guess compared to type 3 or even type 1, in the case that you're saving such amount of resources. I mean, what's your take on that? That must be a big hurdle for the SAS, the reimbursement.
Yeah, we haven't tackled that because we've used in the research environment. We're trying to slowly migrate ourselves in the clinical environment too. But I think reimbursements will need to be addressed. As we adopt this technology, will have to be addressed, because it's not just you're getting 4 or 5 signals and that's it, and you can auto score that whole thing. You are really approximating a type 1 study. So I think the models of care in our field will have to adapt. This is relatively new. Again, it's only available for some years now. We are learning how to use it. We're learning its strengths. We're learning about its limitations. So I think the models will have to adapt.
Mm-hmm. Just sharing the result of the poll, it's highlighting that the signal quality is the most important, I think, when you are talking about polysomnography system. Not a surprise there. I'm gonna, sorry, I have to put an end to this one. We will try to answer most of the questions that are still open in the Q&A and the chat. If you have any questions regarding this, send us an email at info@noxmedical.com, and we'll stay in touch regarding this. Thank you, Dr. Punjabi, for your great presentation, and thank you everyone for attending.
Thank
See you in the next one. Okay, bye-bye.